Why don't we go ahead and get started? Welcome everybody to the first webinar from the Washington Health Alliance for 2025, and we're very excited to be talking about cancer care and the value-based cancer care and what that means and what types of solutions are available to the market. And I'll introduce Dr. Saleh in a moment. Maybe we'll go to the next slide, Teresa. Tell you, just a little bit about the session today. On the next slide, just a reminder that everyone's been put on mute. You should see a chat function in there. So as we get toward the end of the session, we'll start opening that up and looking for questions. Everyone's going to receive slides and recordings of the session as you want that. So not to worry, you don't need to take notes or screenshots or things like that. You'll be okay. And then just a little bit about the Alliance for those that don't know us, and a little bit about our agenda. So this is what we're going to talk about. Mostly it'll be Dr. Saleh speaking. We'll have some time for Q&A. We'll finish promptly at noon, and we really appreciate all of you joining with us. We had 97 people register, so that's great for a session like this. So thank you very much. Just a little plug for the Alliance and tell you what we do. We're entering our 20th year. We are a healthcare coalition. We're different because we have both health plans, providers, purchasers, and other interested parties as part of the Alliance. We do sort of three things. We collect data, we interrogate that data so we can report on it, use that data to identify where we may want to look next, which gets us to that value creation piece. And so we bring in, whether it needs to be an actuary, clinician, et cetera, to really sort of understand and use that data to then help the market drive change to make care more equitable, affordable, improve access, and ultimately be more affordable to the market. And we've got a number of areas that we're looking to leverage to improve access to care for Washingtonians. Alternative payment models, we'll talk a little bit about that today. Navigating to best practices, we'll talk a little bit about that today. Even behavioral health impact, we'll talk about that as we talk about cancer care. So there's a lot of things that we bring to the table to push forward. Next slide. There's some things that we're doing in the future just to be aware of. We have an event scheduled for April 2nd. Everyone, we'd like to invite you to join us. It's really talking about the value, bringing balance back into the value equation for healthcare. It should be almost an all-day event. So in person would be preferred. We're doing some work on chronic kidney disease, as well as a planned webinar on HIV. That's coming up in the next couple of quarters. And then we'll have ongoing work related to chronic kidney disease. We're releasing our community checkup soon, and we're still working on finding appropriate, measurable outcomes for behavioral health, so we can really track, how folks are doing when they get therapy and what are referrals happening in time. But let's get into this talk, and we'll bring in Dr. Saleh. Why are we talking about cancer care? Well, we're talking about it because it is one of the more costly areas. We'll talk about that a little bit more. Certainly for employers, it falls into the top three cost categories for most conditions within an employer-sponsored plan. It impacts a smaller number of folks, but really a larger cost. Cancer is now seen as a chronic disease, whereas when I went to school, it really wasn't. It was sort of a one and done. You treat, hope the person did well. And now we're really seeing people live a long time, but require ongoing therapy, which sort of changes the aspects of the care delivery from sort of episodic to much more of a coordinated team approach. And we'll talk about, how that looks. And certainly we can't avoid talking about, the financial toll of cancer and how it can impact, an individual and make them hesitant to get care. We want to make sure that is not a barrier for folks and going forward. And so we'll talk a little bit about some of the solutions that are out there, some of the components that really should be in place when you think about, a coordinated approach to, comprehensive care of a cancer patient, whether that be expert opinions, making sure people are doing, biomarker testing, genomics, et cetera. Care navigation is very important. Early detection, obviously, as a family doc, that's what I, think about a lot. And ultimately we're trying to get, survivability rates to continue to go up and do it in a way that's sustainable for the health system. So it's great to be able to introduce you to Dee. And Dr. Soleil is an immunologist by training. She spent a decade with the advisory board, who's a place I used to go to all the time to get, useful information about, a variety of different subjects around healthcare and finance. She founded the Cancer Business Forum and is still active in that, and is here really to talk to us about, how do you take an approach for cancer care, and how do we both improve the quality of care as well as the affordability. So, Dr. Soleil, thank you very much for joining us.
Dr. Oliveira, thank you so much for the kind intro. And thank you all so much for taking time out of what I know are very busy days, and already what feels like a very busy year. How is it only January 15th? But yeah, I will just add to that. In my current role, I oversee the development of our cancer program at Carrum Health. And based on my introduction, right, I spent about a decade really doing best practice research in the cancer marketplace and cancer industry. It is where I became really passionate about two things. I mean, a lot of things, but really two things. One is reducing financial toxicity, right? So making sure that no person, when they experience a diagnosis of cancer, ends up going bankrupt, which all too often is the reality. And also changing how we pay for cancer care in this country. I think many of us can realize we are on an unsustainable trajectory. So how do we think differently about cancer and how it's paid for? So on the next slide, you will see, and Dr. Oliveira noted this, right, in the opening comments, a big reason I believe, I think a lot of folks now are laser focused on cancer care and thinking about benefits for their employee population is because of the costs, right? So it is just rapidly increasing. It has now been cited in the past 2 years as the most frequently cited condition driving costs for large employers in the Business Group on Health annual large employer survey. And when we have done surveys on our own, and also there's a PwC survey that we will refer to in this presentation, can see a lot of employers report that about 16% of their healthcare spend is attributable to cancer. And again, Dr. Oliveira made this point, right? It's usually about 1%, right, of members and like total volume of claims that are related to a cancer diagnosis. So again, relatively small incidence, thankfully, but a huge portion, and a growing portion of total healthcare spend. As you can see, employers estimate that their cancer care spend is going to increase by an average of about 9% per year over the next 3 to 5 years. And when we think about costs of cancer, it's not a simple equation, right? So for cancer treatment itself, costs are driven by things like surgical care, imaging, labs, hospital admissions, ED visits, physician consults, and a lot of the biggies, radiation and chemotherapy, immunotherapy. Drugs account for a huge part of the average cancer patient spend. This varies by insurer as well as by tumor type, but overwhelmingly, right, it's a huge area of focus. And I think when all of us to think about cancer costs, right, our brains automatically sort of go to the drug spend. And so our focus, as we've been thinking about our cancer care offering, we really want to tackle the entire continuum of care with a hyper focus on things like radiation, on chemotherapy, on surgery. So that's sort of a big picture, right? The costs and the growth in costs. On the next slide, you'll see a little bit more data that comes from a survey that was done across 2024. So, Teresa, if you can go to the next slide, please. This was a survey of over about 100 employers responded to a survey. There was also a number of interviews to help provide some more context. And this was asking about the current state of cancer costs and benefits to really understand employers' priorities and, what are they currently doing to try to wrap their arms around this really sticky, really complex issue. So when employers say that their cancer spend is going to increase 9% annually, when we dig beneath that a level, and we look at tumor sites, right? So we look at, there's a number of different, we say cancer, right? It's hundreds of different diseases. Breast cancer was most commonly cited as the number one spend by diagnosis. Often I think, right, is because of the incidence, right? Especially in the working population. And statistics now, I believe, are 1 in 8 women are likely to experience a breast cancer diagnosis in their lifetime. That is then followed by lung, which relatively lower incidence compared to breast, but really costly, especially because unfortunately it tends to be diagnosed at later stages. And then that's followed by colorectal cancer, high incidence, and alarmingly, right, there's been a lot of headlines over the past year or two about the increase in colorectal cancer diagnoses in the younger population. So really, I think that's a big one to keep an eye on and really think about, as we'll talk later, early detection and screening. How are we making sure folks are up to date on their colorectal cancer screening? And in the bar chart on the right, when we look at the areas of spend, so thinking about the different sort of pieces of the provider ecosystem where spend is happening, number one was outpatient services, which includes infused and injected drugs. So like chemotherapy, immunotherapies, then medications, followed by inpatient, and then lastly, diagnostics and imaging. So bottom line, right, cancer costs and trying to think about wrapping our arms around the cost is really complex. It's going to vary by cancer type, cancer stage. And of course, we have to consider the impact beyond the pure cost to the plan. And so on this next slide, you will see, right, the humongous impact that cancer has on the people and the families experiencing a diagnosis. I don't need to belabor this. I think so many of us, right, have personally, friends, family, ourselves been impacted by a cancer diagnosis. There are 3 big things that really at Carrum we are aimed on trying to fix. The first is financial toxicity. So I've already spoken to this, but those folks who are diagnosed with cancer are 2.65 times more likely to file for bankruptcy than people who do not experience a cancer diagnosis. And if you file for bankruptcy, your likelihood of survival is cut essentially in half, right? So the financial toll is immense. And it is just a humongous burden, right, when it comes to quality of life and ability for people to focus on getting well. The next big piece, this administrative burden, is something increasingly in the cancer world we're calling time toxicity. We like to sort of take things and put toxicity on the end. But really, there's a huge burden when it comes to scheduling, getting to appointments, coordinating calendars, coordinating across providers, gathering and filling out paperwork, getting on the phone and arguing with your insurer about why did you deny, this prior authorization. There was a survey from Memorial Sloan Kettering that came out in about the past year, and it shows that 2/3 of cancer patients have to become involved in the prior auth process to receive the care that they need. So, not surprising to many of you, about 70% of patients experience depression at some point in their journey, and actually over 35% of breast cancer patients still meet the full diagnostic criteria for PTSD even after active treatment is complete. So there's so many reasons for us to think about how are we improving the cost to, right, employers, the cost to the people and families, and also all the emotional burden and the pretty crummy experience most people have to go through. And this is even heightened on this next slide. You will see across different populations, right? In healthcare, coming out of the pandemic, I feel like one of the few silver linings is that in healthcare, we're talking a whole lot more seriously about health disparities. We see them widely across the board in this country. I think it is especially the same for cancer care, where health disparities are rampant. And the end result is that we get these hugely disparate outcomes for different disease types based on race, language, socioeconomic status. Truly, your zip code has more of an impact on your risk of developing and then surviving cancer than your genetic code, right? So for all of our employers out there, I urge them to think through, your populations, the potential social determinants of health in your populations, and then how do we make sure there are benefits and interventions and ways to help address those. So as Dr. Oliveira said in his comments, right, equitable, affordable, accessible. And currently, right, we are not supporting equitable, affordable, accessible access to care across, all the different populations and communities in the country. Okay, so that was sort of a lot, but right, in terms of problem setting and why I think we're seeing cancer come up so much more in our conversations around benefits design. So let's sort of talk to what we are seeing employers really zero in on and be concerned about and think about when it comes to benefit design. So on this next slide, you're going to see a bar chart in this beautiful spectrum of pinks to purples, where employers were asked, what are the most important challenges you face when it comes to managing cancer diagnoses and treatment for your employees? And this was on a 5-point scale, 1 to 5, 5 being very important. Bottom line, right? All of the options scored over a 4. So the importance of not letting folks choose everything as important. But I think that is reflective, right, of where folks are. So you can see at the top, containing costs, number 1, then mental health, better employee experience, improved quality, managing multiple stakeholders, right? Cancer is now a chronic disease, as mentioned, and involves so many different pieces. There's also sort of navigating boundaries and personal nature of cancer, education and benefit support to employees, and then really for employers and their teams, right, understanding the oncology benefits market. So, I think in Dr. Oliveira, please feel free to chime in. Like, I'm not sure what this says to you, but to me, it just kind of says like, help, everything's important right now. Everything is a priority. Either how do we prioritize or how do we think about making a really comprehensive strategy to address this?
Yeah, Dee, I think, sometimes it's almost overwhelming from an employer standpoint in terms of where do I start next? Yeah, I want to improve, healthcare costs and I want to do all these things, but is that my role? Is there is there an easy button I can hit, to to just allow the health system to take care of, my members so that they, can do well, or their family members can do well. They can continue to be productive within the community.
Yeah, exactly. I love that, right? Is there an easy button? Is there a one-stop shop? Is there a silver bullet? Cancer is so complex. It's certainly what we're trying to do, but it is right. There's just so much complexity and nuance here. So yeah, thank you for that. I fully agree. Okay, so the next slide. So, okay, things are really important. And number 1, containing costs. So the next survey question I just wanted to highlight is, okay, so, what are you currently doing to control oncology costs? And the number 1 thing that folks said they were doing was, working with vendors to manage quality. Followed really closely behind that is increasing or, prior auth requirements specifically for medications. Third was managing end-to-end care and working with vendors. So in my mind, right, that's sort of like navigation vendors. And then fourth was moving patients from inpatient to outpatient settings, and then only 3% saying they're not taking any action, right? So folks are starting to look for it. What are the solutions? How are we doing this? And I think this fourth one is really interesting. So Dr. Oliveira, heads up. I'm going to call on you again, right? I didn't write the survey question. And rather than talking about the site of care shift from inpatient to outpatient, that's really not at this point as much of an opportunity in cancer care, right? We've moved a ton of care outpatient at this point. But really, the site of care shift that we talk more so about in oncology is really about moving from hospital outpatient departments to community oncology or private practices. So, Dr. Oliver, would sort of love to hear your thoughts on that. If you see things happening in this space, what employers should know about that site of care shift?
Yeah, I think it's hard from an employer to sort of dictate that. I think what we try to get to is, do we have providers or provider systems that are really taking into account where that patient needs to get their care. And sometimes they need to be at a higher level just because of complexity and maybe they've had reactions to some of the treatment. And other times they can be, dropped down to an ambulatory surgery center and a physician office, sometimes even at home. So whatever the best place, the best chair to sit someone, that's where they want to get the care and what's most convenient for that individual as well. That's going to help with compliance and, family support and things like that.
Yeah, exactly right. I think that is like the magical key we've been talking about in cancer care for a while is right care at the right place in the right setting for the right patient, right? Like really, where do they need to be, and what is given their clinical complexity, and their needs and their diagnosis, all of these things, right? What is potentially the highest value and or like most cost effective site of care for that person. So, yeah, lots of conversation there. And as we move on to make sure everyone is awake and staying with us, Teresa's going to launch a poll. So, what we would love to hear is for everyone on the line, where it applies, what are you doing or what have you done to improve cancer care across your population? So, choose all that apply, right? Have you implemented a COE or value-based solution? Have you implemented mental health and wellness support? Do you have provider incentives in place to encourage cost-effective therapies, care navigation support, second opinions, early screening and detection, and or are you planning to address improvements in the coming year? So we'll give you all, yes, thank you, the note from Teresa, our fearless administrator. Scroll down to see all the options if you can't see them. And again, you can select all that apply. So we'll leave this open for a few more seconds. I'll stop jabbering and let you concentrate.
Hey, Dee, while we're waiting, there's a question from Sarah Green about prior authorization requirements by employers. And is it part of patient-centered care, clinical autonomy? Is it only when medications don't seem to be either evidence-based or within a guideline? What are you seeing folks do from a PA standpoint, or is it more relying on the health plan to sort of create that PA process and they're a little bit more hands-off on what's going on?
Yeah. For the vast majority of folks, it's much more relying on the plan and their PA and utilization management that they already have in place. I will say, and I'm going to answer this with a bit of the provider perspective. So, Dr. Oliver, you could keep me honest here. I think across the board, and especially in cancer care, because of the cost, we just continue to see increase and increased prior authorization requirements. There's pretty clear evidence that oftentimes it delays care, even when it's going to get approved, or maybe it's denied and then gets approved. It has a pretty big impact on patient care, patient satisfaction, obviously provider satisfaction, and how much time providers are spending chasing this down rather than trying to spend with the patient. Um, so I do think there are some solutions out there that are trying to streamline the prior auth process and make it a little bit easier on providers. And I will just share with all of you from the Carrum standpoint, and we'll talk about our quality evaluation, but essentially we partner with providers who we know are delivering evidence-based care so they can demonstrate adherence to NCCN guidelines. That is like the baseline for evidence-based care in cancer. It's the gold standard. It's NCCN. Also, a lot of our practices and partners that we work with are on what we call in cancer clinical pathways. This is a clinical decision support making tool that tells providers when they're prescribing, the chemotherapy, what is the best option for this person based on efficacy, toxicity, those things equal cost. And so it gives us really good insight into how much evidence those providers, right, are they really delivering high value evidence-based care? And if yes, then we essentially gold card them where we waive prior auth requirements. We have seen some payers, I know there's like a plan in Texas that's doing this, where if you are consistently able to demonstrate that your doctors are delivering care that is in line with evidence, they will sort of waive those prior auth requirements. And that's the tack we want to take to reduce all the administrative, all the time, all the things, right? All of the things that are spent, all the money that's spent on that administrative piece of it. It's a really long answer to that question, but hopefully that helps. As y'all can tell, I could talk about this topic forever. So, you'll have to rein me in. And on that note, Teresa, do you mind closing the poll and sharing the results so folks can see? Awesome. Okay. So y'all can all see this, but number one, care navigation support. That makes sense. We see that come up a lot. It is how do we improve the process end to end? It's nice to do. Oh, 57% early screening and detection. That's great. That's been coming up so much in conversations, followed by mental health and wellness support, which is great. And then we've got only a couple folks saying COE value-based solutions, which is interesting. We'll share some data in a second here. And then second opinion support, a smaller number, and then a lot of folks planning to address improvements in the coming year, which is awesome. So thank you guys so much for sharing that. We can sort of close those, and I want to share with you all what we saw in the survey when we were sort of thinking about, okay, what offerings or services are most important when you think about selecting an oncology solution, right? So when we're sort of thinking about the improvements, how do we think through all these options? And so Teresa, on the next slide, if you can share that with folks, you'll see here, this doesn't mean folks actually had implemented it, but a lot of interest in COE and value-based solutions. We're going to talk more about that because a COE is a COE is a COE. How are people defining it? All very important to understand. Followed by mental health and wellness support. I think that is speaking to the incredible toll we know that a cancer diagnosis takes. Then provider incentives for cost-effective therapies, then care navigation support, then second opinion support, then early screening and detection. So again, a lot of info here. I think a lot of it aligns, but also just interesting when we think about where is there some real potential to wrap our arms around costs and how folks are thinking about that, especially what I selfishly focus on, right, which is COE or centers of excellence or value-based specialty solutions. So we're going to define that in a second here. Teresa, if you can just go actually to the next slide and then to the one after. It is really important, I think. Again, we say center of excellence, and if I asked probably all of you to give me your definition, it might slightly differ. When we asked employers, Dr. Oliveira, I'm going to call you. So a heads up for your definition of COE, especially in cancer care specifically. When we asked employers, number one, they said treatment bundles, which I'm going to say value-based payment, right? But sort of it encompasses the actual payment side of things, right? Encouraging value. Then something that covers all aspects of cancer care. So a one-stop shop, then you see a broad network, right? And we'll talk about access, local access, especially for radiation. You're coming in every single day, especially for chemo. You feel terrible. Visits are really long. You're coming in weekly or every other week. Local access critical for quality so that folks stay with their treatment and don't drop off. And then active steering to lower cost, high quality facilities. Then a vendor offering other solutions in addition to oncology, right? So is there an ease? It's not just cancer, but I can also add in, joint, spine, blah, blah, blah. Then mental health support, and then at the bottom, pediatrics. So, Dr. Oliveira, anything you'd call out, or can I put you on the spot for when you think about COE for cancer, what the heck does that mean to you?
Yeah, I think for me, y- cancer care is really a team sport. So I'm looking for a team-based approach that has sort of all those aspects in there that can help that person. Typically, you think about local services rather than, having someone have to get on a plane and go travel someplace. Although sometimes that's the best place for treatment for some rare conditions. But for the more common ones, especially the, top three, solid tumors that we were talking about earlier, that's going to be, should be able to be handled in a more local setting. But they really should have all those pieces in place. They should have, you know, um, whether it's care navigation, mental health support, all those pieces should be in place, as well as guidelines to help drive them to make sure that they're not, missing, certain genomic testing, biomarker testing, et cetera, to help guide treatment. So it's a very comprehensive approach. That's where I
Mhm.
think about it. The other
Yeah,
piece I think about is they should have their payment aligned with outcomes. So a value-based payment, an episode of care payment, something like that differentiates them, I think, from usual care.
excellent answer. I'll give you gold star A plus because yeah, I love I love highlighting, especially for cancer, collaborative, team-based. And then to be honest, where cancer is far behind other specialties, it is in actually how are we tying the quality and the outcomes to the payment. And for many, many reasons, cancer has lagged behind, right? It's much more complex than coming in for a knee replacement. So for very good reason, but lots of opportunity, I think, to do more when it comes to that in cancer care. And I will say, using that to kind of talk about our perspective at Carrum. And on this next slide, you'll see, I think, especially when we think about cancer and we think about it being cross continuum, there are a few big inflection points to really drive value, right? So to reduce costs as appropriate and also to improve outcomes and quality of life. The four big ones we really focus on are number one, the issue being too many cancers being diagnosed late. Um, there is still a real lack of uptake of cancer screenings that have been endorsed by the USPSTF, right, the Preventative Services Task Force. And that varies. So for mammogram, we see quite high adherence relatively for things like lung cancer screening. It's something like 4 to 6% of eligible folks getting those screenings as recommended. So huge opportunity there because, of course, the earlier we can diagnose cancers, the much better survival rates are going to be, and also the lower the costs are going to be. There's also incorrect diagnoses or treatment plans that are not sort of grounded in evidence. And so I'll talk about this in a second here, but you'll see we're partnered with Access Hope, which is a great partner. And really the goal here is to make sure people have the right diagnosis. It is far too frequent in this country that people with cancer have a misdiagnosis or wrong diagnosis. Studies say somewhere between 10 to 20%. And then also making sure people have a treatment plan that is aligned with the latest and greatest evidence that's going to give them, the best shot at survival, and also find opportunities to maybe find, a less costly sort of plan of care if appropriate. The third big one is providers incentivized on volume, right? So under traditional fee for service, um, a provider is not necessarily incentivized, right? Or they're not paid in accordance to cost-effective care, high-value care, evidence-based care, and then based on what the outcomes of folks are. And again, this is not the fault of oncologists, right? Again, it's just the industry has been a lot slower to create models that are workable for cancer care and that do this. And then the last piece is not meeting someone's full spectrum of needs. So again, right, thinking about all of the symptom management, the psychosocial support, the financial support, that's really important to keep patients as healthy as possible across their entire journey. And as a result, right, if we keep patients healthier, if we're addressing their symptoms and their needs proactively, saving costs ultimately, right, by reducing ED visits, unnecessary or avoidable hospitalizations. So when we think about how we are designing our program, our cancer care program at Carrum, a lot of it is really grounded in that. And so it is on the next slide. Teresa, we can skip the next one and just hop to Carrum. I'm going to give you very, very brief. I'm keeping my eye on the clock. So I'm going to keep my comments brief, but just to give you all sort of an introduction to how we think about this. We are at our core, and we were founded over 10 years ago, really focused on driving value-based care and centers of excellence. We did not invent these models, right? But we really saw an opportunity to create a solution to focus on this business model, to make it more effective and more scalable, to make sure employers and all of their employees and dependents have access to high quality, high value, more cost-effective care. So we work really closely with providers across the country um, to evaluate them on their quality. I'm going to talk about what that looks like for cancer care in a few moments here. And then also enter into value-based payment contracts where we are aligning incentives on appropriate care and also quality outcomes. We layer beneath that our care specialist team who just helps be the backbone and the net to make sure people don't fall through any gaps in care across their experience. Again, for cancer, we're talking usually months, if not years, of services being received and an experience and a journey through the cancer care continuum. And then we have a tech platform to ease sort of patient use if they want to do that, or calls by the phone, and just have everything accessible to patients so they can really have an idea of the provider and the care that they're going to receive. We started our value-based care COE network in musculoskeletal. So started, with hip, knee replacements, spine, bariatrics also. And then one of our most recent service lines that we really created about a couple years ago and rolled out in earnest across our employers and have really started building out our network is cancer care. And for cancer care on the next slide, you'll see our goal here is to create that sort of one-stop shop where you come to Carrum and we have the ability to provide services, to provide support to someone with a cancer diagnosis, no matter where they are in their journey, no matter where they live, no matter what diagnosis specifically they are dealing with. So we really start engaging folks on the front end by doing marketing and outreach and education, of course. We also have partners for screening and detection. You'll see them, their logos here, Color and Grail, where, for instance, for Color, if an employer partners with them and they can turn them on for ease of contracting through Carrum, and we're integrated our pipes for patient referrals. Color works with American Cancer Society to drive the major screening. So mammograms, colonoscopy or, colon cancer screening, prostate, lung, and then GYN, cervical cancer screenings. And so someone could partner with them, really get the word out, right? Get your screening, stay adherent to this. And then when someone is diagnosed with cancer, they can enter into the Carrum program. We have a navigator team who helps understand their situation, what they're looking for. Is it psychosocial support resources? Is it a second opinion? Is it actual treatment? And sort of how do we connect them through our programs? Again, you'll see the main programs we have are our cancer treatment program, which I'll talk a little bit more about. But this is really partnering with providers across the country to deliver value-based cancer care. Or someone might come in, they need or want a second opinion, or they live somewhere really remote, they're not able to travel. And the goal there is, can we make sure you've got the right diagnosis and your treatment plan is right? And we do that through our partnership with Access Hope. And then ongoing support, because right, again, it's a long journey for so many people. How are we making sure we're supporting their needs, whether it's finding help with transportation, support groups, whatever it might be. I'm just going to double click into a couple of these things. You'll see on the next slide just a highlight of our Care Navigator team, because truly, right, this is a very unique person who's able to do this. They lead really with empathy. They establish such tight connections with the folks who come through our program. The thing I'll really call out here, what we've been very mindful of, is not confusing or overwhelming the patient. So really trying to think about, what is our role? How do we work with maybe other benefits navigators an employer might have in place? How do we work with our treatment centers of excellence that we're not duplicating and not confusing, but really adding value and being that support when patients need us, right? And they know they can come to us for any resources that they may need. When it comes to our treatment program, I'm going to spend a little bit of time on this. You'll see on the next slide, because this is where my team spends the majority of our time, is really thinking about how do we create a network of cancer providers that is rooted in value-based payment so that we are, right, again, changing and aligning provider incentives to drive highest quality, most cost-effective care. So that is what we focus on in our providers. They will provide diagnostic and treatment plan review. They'll say, here's the treatment plan, deliver the treatment as appropriate and related care. So symptom management, right? Diagnostics. There's a lot of wraparound support that goes into this. So nutrition support, social work, things like yoga classes or Reiki might be offered and available as well. And then follow-up visits. And again, the Carrum Health navigators there to really help support as needed, while our treatment centers of excellence become the main point of focus and communication for our patients. I will say, as we've been growing our network and really thinking about value-based care, when we think about value-based care, there's of course the cost component, there's also the quality component. So on the next slide, you'll see how we think about quality at Carrum. There's no singular, universally accepted approach across the country to quality evaluation and cancer treatment. So we have three big components of our quality evaluation. The first is we do quantitative. So we evaluate performance on a number of different measures that will include volume, symptom management, patient satisfaction, reporting and measurement of pain, end of life care. There's really a lot that goes into this. It tends this is where a lot of our partners, our provider partners are like, D, are you serious? But it's really important, right? However, a number is a number is a number. And in cancer, I don't think one number is going to tell the whole story. So we also do a programmatic stakeholder interview. And this is where we really get behind the numbers to understand, how does this cancer program engage patients? How do they think about access and timeliness of care? Dr. Oliveira mentioned this. How are they facilitating team-based care across different specialties? What is their focus on quality improvement? And sort of what are all the different support services that they may offer? And then the last piece is that our team does a site visit where we go and spend a ton of time, sometimes virtually, most often in person, where really our goal is to understand from the patient perspective, what does it feel like? What does it look like? Who do you meet? What does that journey through this center look like? Usually about a half to full day of interviews. Honestly, it is a tremendous privilege for our team to get to have that experience. And then the last piece, our third pillar, is really the savings piece, right? So on the next slide, and you'll see when we talk about value, we will talk through this, right? And so it is, our goal is to have up to 30% savings per treatment episode. It's going to vary a little bit based on the diagnosis, the market, all of those, what the treatment the patient's receiving. But our goal is, depending on utilization and how much employers partner with us, impacting potentially reducing up to 10% of total cancer spend. Really, the goal is for all services that are delivered through our program, there's a $0 out-of-pocket cost for patients, which is tremendous and a really, really, really core component and the reason why I came to Carrum to work on this program. So with that, I'm gonna probably wrap us up. We have a couple of more slides, but I know we've got a whole lot of questions. So Teresa, maybe you hop to the next slide, or we could actually just hop to slide 36. Sorry, y'all. I'm gonna instead of marching you through all these slides, you'll get them and follow up. But just really quickly, we stood this up again a couple of years ago and really emphatically rolled it out across. I'm trying to think of the years, goodness, across the last half of 22 and into 2023. So a lot more results coming out. But this is our case study and really our proof of concept with Prudential, where we launched this. They had been trying a whole number of things, trying to wrap their arms around cancer costs, had a number of different solutions in place. And so they really were a great partner for us in standing up our cancer care program. And you can see really high utilization. They're very engaged and have great outreach to their population with savings of about $17,000 per treatment episode. So a lot of results to come this year. And then also, of course, what we care the most about is actually hearing from our patients. And so on the next slide, you can just see a link. Again, if you're interested in follow-up when we send these slides out, you can always hop to this. But, that I think is the reason so many of us are invested in cancer care, and certainly why we are focused on building out this program is to just have much more of an impact on people's experience and try to make it a little bit easier and a little bit less painful and burdensome. Okay, so with that, I'll wrap. Teresa, if you want to go to the Q&A slide, I'm going to take a sip of water, and Dr. Oliveira or Teresa, we can talk through them.
I'll get my mug back on here. So a couple of questions that'll probably be pretty quick, but maybe not. One is related to the payment mechanism that you guys use with your preferred provider organization. So is it a bundled payment? Is it some other weird arrangement? How's that work?
What a good question. Okay. So there are two mechanisms. I'm gonna try to give y'all the short version, but as you can tell, I can be pretty long-winded. But when we started, and really what we were rooted in was bundle payments, so prospective bundle payments. And we developed these in partnership with Memorial Sloan Kettering. We have since expanded across the board. And they're great, right? They are 2-year episodes and they account for the different pathways. So we started in breast just because it is, relatively speaking, non-metastatic breast is more predictable. There are very clear pathways. We set up bundles for like if a patient just needs surgery or if they get a lumpectomy and radiation, or let's say it's a lumpectomy and chemo, right? So we sort of have bundles within the bundle to account for the big cost drivers. What I will say, what really we have learned is it is really tough for a few reasons to have bundles across the board in cancer. When there's a lot of cancers that are rare, that are metastatic, right? So advanced disease that are, thankfully, we live in a time where cancer treatment is evolving really rapidly, right? We are learning a lot. Dr. Oliver, you've mentioned genomics a few times, right? We are seeing precision medicine really explode. Right now, if I developed a bundle for rectal cancer, it's probably going to be out of date in 6 to 12 months. So like, no one's going to do that, right? So it's really thinking through where cancer is bundleable. And so breast, we have thyroid. We also have them for CAR T cell therapy, which is a little bit different, and are putting them in place right now for prostate as well as for colon. But for patients who are rare disease or they're metastatic or it's a recurrent cancer or a number of other factors, they might not fit into the bundle, right? The bundle is for a relatively lower risk profile so that providers can take on that risk, right? As cancer, it is really complex and expensive. And so we also do now have a more expanded value-based payment program that we have gone live with. We've got about 300 individual locations across the country set up, and we'll just continue to grow. Because again, especially for chemo and radiation, hyper-local access is really critical, where we are tying provider incentives to quality outcomes. So it's more of a pay for performance model where they have to deliver results on evidence-based care, patient satisfaction, timeliness of care, and symptom management. So again, kind of a long-winded answer, but we want to still bundle where it makes sense and we can. But also, we have so many folks who come to us who don't fit into a bundle. So how are we still taking care of them while aligning provider incentives to cost-effective care and to high-quality care?
Yeah, I think bundles were sort of, talked about, for years. Pretty easy with some surgical procedures like,
Yes,
you're going to take care of my
my
meniscus and my
hip.
knee. That's pretty easy,
Hmm.
right? But cancer's always been a little tougher one. So it's interesting to hear, the flexibility as well
Yeah.
as the multiple different pathways that you can go. What happens when someone might be in a clinical trial, though? So how does
Yeah.
that impact the care that the Carrum team, because it's a Carrum team that's doing the navigation and all that, right? Not another team.
Hmm. Hmm.
How do you manage maybe where there's some overlap with a clinical trial?
Yeah, so clinical trials are an interesting one. From the jump, we have always said, I never want to have a patient either opt into the Carrum program or be in a clinical trial, right? Because those two things are great. We want as many people to benefit from both of those things as possible. So patients can be enrolled in clinical trials and be in the Carrum program if they're in a bundle, right? And so then the trial sponsor, usually the pharma company, is paying for the drug, then that just gets removed from the bundle, right? So if they're getting that drug and radiation, it becomes a radiation bundle. And then in our more alternative, sort of the value-based payment system, those patients still count. And just that those costs, again, what the vendor is covered by the vendor. So how it would normally work, but the other care comes through us. But yes, we want, and when we talk about health disparities, right, that is where there is a tremendous opportunity to get more, especially like older populations, Black and brown populations, right, the BIPOC community, get more folks involved in clinical trials. So we really like to enhance access to research when and where possible.
So really as a way to be an adjunct to providing high quality care. One of the things I think you passed through pretty quickly
Hmm.
was sort of when someone might need an expert opinion, and I know I saw the slide pop in there, but it popped past me really fast. I'm not that quick. Um, not everyone needs an expert opinion, but I think some of the data. I remember the study out of Mayo where they looked at their own oncologists and
Yeah.
they found that 20% of the time they had the diagnosis wrong.
Hmm.
And, like most, you'll see about a 60% modification of, maybe a treatment plan.
Yeah.
So how do you decide when or when not to, refer someone into, just get a little higher level look see?
Yeah. So I'm going to tell y'all there's two different routes. And actually, Teresa, please don't get mad at me, but it actually might be worth pulling this slide up because I think it was really helpful. If we go back to slide 28, it's going to highlight Access Hope really quickly because to your point, right, we do know a lot of cancer diagnoses are incorrect. A lot of treatment plans aren't necessarily aligning with evidence or, right, maybe it's overly aggressive care, right? So, yeah, there's a lot of instances. I will say our take is twofold. And so, Teresa, on the next slide, you'll see there's two approaches to Access Hope. And the one is um, person initiated, right? So, any person who comes to us, we're not going to force them to get a second opinion, but a lot of people come to us and say, hey, I want a second opinion. And we say, okay, we're going to tell you about this benefit. And if you're interested, we're going to connect you. And I'm going to say to your point, yeah, not everyone needs one, but I do think Again, we don't force people into it, but when I have someone personally in my network who has a cancer diagnosis, that's usually the first thing I say is go get a second opinion. Like, make sure you feel, even if it's just validating, you feel more confident in what is happening. So that's a big one. So that's one way, right? Members can come to us, they can receive it that way. The other way, really to your point, how do we make sure? Because it's hard to engage cancer patients when you're going through cancer, you're so overwhelmed. The other thing Access Hope has in place is what they call their APO, Accountable Precision Oncology Program. This is claims driven. So through our partnership, folks can contract with Access Hope and they will get a stream of data, the plan where they have an algorithm to identify the cancer diagnoses that involve complex treatment decision making. And so it's, usually about 35% of diagnoses might hit this. And then Access Hope really will proactively just reach out to the treating oncologist, say, hey, we're a service that is offered for XX, Miss Smith. Would you like a second pair of eyes on this treatment plan, right? Like, how can we help and support? And then the oncologist might say, sure, that is great. Send records, they'll review it, they'll send their report back. And so it was a way to sort of make sure that when it is really, really, really going to add value, it's not putting more work on the patient to proactively reach out for this, but just making sure that's happening. And I will say just the last point on this, I'm definitely unbiased because I've worked with cancer providers for so many years, but like it is really a very multidisciplinary, very team-based specialty. It just has to be. And so there's really high uptake from the treating oncologist often to take advantage of this service. So, and Access Hope, of course, has a ton of information online for folks who are interested in that as well.
There's a bunch of questions that have popped in there, but there's a couple of them related to, there's one related to data and like,
Mhm.
do you publish that? Where do you get it? How do is it all proprietary? How's that?
Oh, the data that we're
Yeah,
getting to evaluate
yeah.
providers.
And,
Yeah.
and sort of tagged to that is from an employer standpoint, are there performance guarantees that, are offered to an employer?
Yeah. Well, on the latter, I will say I'm going to defer to our commercial and sales team. They're happy to talk PGs with people. So they will happily discuss that. And, like, yes, we're always willing to entertain that, especially and what is so important for cancer is when employers are bought in on the program and help us reach out and educate to members. Um, so for sure, if you're interested, we can always talk more about that. I
Okay.
will also say, so the quality data. What we do, to be honest with y'all, is we get very scrappy. So we purchase a ton of claims data. We have a partnership in place because, again, there's not great healthcare quality data that exists in the country for people to look at. And so we purchase a lot of data and are able to look at a lot of these different um, quantitative data elements and sort of scores and performance across different providers based on that. But yeah, we are really sort of scrappy in terms of using all the data we can, whether it's purchased, some publicly available sources, and then also we'll work with the providers as well. There's also a question from an anonymous and about OCM, oncology care model. I could talk for days about that. But also for a lot of folks who have participated in OCM or EOM, enhanced oncology model, it's the newest ongoing current CMS demonstration project for cancer care, or folks who are in Commission on Cancer, which is a certification. We will also leverage data from those sources to see their performance, understand national benchmark, et cetera. So healthcare quality and cancer quality very messy. So we really do use a number of different sources to get a picture of that provider's performance.
And I know we're right at the top of the hour.
Hmm.
Maybe what we can do is we can, respond on some of the other questions that might need a little bit more detail. Also, there was a question about healthcare disparities and how the program has started to impact that, if at all. But I wanted to say, a big thank you to Dr. Saleh for coming to speak with us. We're happy to provide any other information that folks may want to know. And I think the whole idea is, what are other solutions that might be out there? I like how Carrum has sort of started putting together from the screening standpoint, even the more complex issues related to the like use of Project Hope, how it sort of brings the local oncologist into that fold rather than having someone externally doing it to you. It's doing it for you. So I think all of that is fantastic, and love to have more conversations with you going forward, and appreciate the Carrum support and appreciate everyone's support for the Washington Health Alliance. Thank you very much.
Thanks so much.